should see my screen now.
Mm-hmm.
And then
Perfect.
okay, that's that. Let's see the participants. So attendees, there's 3 people there.
Yeah. Our last lecture ended kind of early, so I think some of them logged off, and I think they'll come back.
Okay, no worries. Well, let me know when you want me to get started. So.
Okay, feel free to go ahead.
Okay, all right. Let me put this up. Sarah, do I need to unmute them, or they have the ability to unmute if they want to?
They do not have the ability because we're in our webinar format, so you'd have to unmute them. They can raise their hand if they want to talk, or you can go in and unmute them.
I actually don't see the button to unmute them.
Oh, to allow to talk, does that not show up for you?
No, it just says
okay.
chat. So
I can do that as well for you, but let me make you a co-host, and that might give you that ability as well. Do you see that on there now for the attendees?
Participants allowed to talk, yes.
Yep.
So let me just allow them to talk if they want to.
Okay.
There you go. That is that. All right. Good morning, everybody. Thanks for having me participate and go over these radiology slides with you. This is one of the talks that I give at the Academy every year on advanced temporal bone imaging. This is really your time. So it's meant to be an interactive talk. So you can just unmute yourself at any time. And if you would like to participate and ask any questions, please go ahead and do so. I can get rid of my own video to not be distracting you guys. There we go. All right. So let me go down quickly during the talk. All right. So the advanced portion of this lecture, I'm going to go over some radiology images on dizzy patients, pulsatile tinnitus, CPA tumors, and petrous apex. This is meant to have polling for the audience, and we can't do that. So please just in your chat box, you can type in what you think the diagnosis is, and I'll wait till you do that, and then we'll go over the next one. Just to give you some idea about temporal bone imaging resources for you, I've heard over the years that this is one area that the board examiners find that our residents don't have enough experience. And unfortunately, a lot of community colleagues, they really heavily rely on their neuroradiologists and community neuroradiologists to read their films for them, and they just read the review. So we try to avoid that. And some very good resources for you. We just did a massive temporal bone radiology talk for you on Academy U, which I understand now it's freely available to you especially during COVID-19. These talks, I've been giving them since 2014 or 13, and they are available on Academy's website as well. And there are different sort of basic level, advanced level cases that you can go through. 2 very good books for you on neuroradiology. The chapter that Nancy Fishbein wrote for the Lang book that Anil Lalwani is the editor for is a superb chapter to refer to, especially for board review. And my friend Richard Gergal also wrote a very nice book on head and neck neuroradiology that's been published and available as well. So you can refer to either one of those 2. But if there are no questions or comments, we can get started. Let me make sure if there are any new participants, if they're allowed to unmute themselves, and we're good to go. All right. So on to the first case. In general, the caveat here is that imaging for dizzy patients are rarely indicated. It is very unusual for me personally to order an imaging study for dizzy patients. So what you're seeing are sort of advanced cases, rare cases that patients present with vertigo that because it's accompanied by facial paralysis or hearing loss, that an imaging study is indicated. So this is a patient that presented with facial palsy, hearing loss, and vertigo suddenly all at the same time. There were really no other risk factors, and there's nothing on the physical examination besides the right beating nystagmus when you put Fresnel goggles on her. So what you're looking at here is a Fiesta sequence, which is a thin slice T2 sequence. You're looking at the right internal auditory canal. You can see the nerves that are traversing there, and you can see the cochlea there, the lateral semicircular canal, there's the vestibule. There is a coronal T1 pre-contrast image that you're looking at here. This is the right side, this is the left side, obviously. You can see the IAC. That little black triangle that you see here, that's the transverse crest. So that's the upper or superior portion of the contents of the IAC. That's the inferior portion. You can see the vestibule there and the superior semicircular canal. This is pre-contrast, and what happens when you give contrast, this is what you see. There's a linear enhancement in the superior aspect of the internal auditory canal. Now, putting that together with a patient who has facial palsy, hearing loss, and vertigo, what is going to be your diagnosis? This is the axial of the same cut. I'm sorry, there's the axial cut of the same MRI, and we can see the enhancement in this triangle there. So in your chat box, you can type in what you think is the diagnosis for this patient. Let's see, do I even see the chat box here? Okay. Not seeing any chat, so I don't know if anybody you would like to raise your hand or speak up. You can unmute yourself. But in any case, this is a case of polyneuritis. This is a CN7 and 8, so it's a facial nerve and cochleovestibular nerve polyneuritis. It's very similar to Bell palsy in the sense that Bell palsy is a viral mononeuritis, if you think about it. This is a patient that has polyneuritis. This is not Ramsay-Hunt. As I mentioned to you, the physical examination was normal. The patient did not have any vesicles, so this is most likely not a varicella zoster activation. This is probably an HSV activation. What rules out vestibular neuritis, which would look identical on imaging, is that this patient also has facial paralysis and hearing loss. It's not a normal geniculate ganglion. You do not see that linear enhancement in the superior aspect of the IAC with a normal geniculate ganglion. Okay. Facial nerve schwannoma, unlikely for a facial nerve schwannoma to cause such linear enhancement and also cause hearing loss and vertigo at the same time. And perineural invasion, again, is very unusual, especially with presentation of a sudden sensory nerve hearing loss, facial paralysis, and vertigo attack. So let me move on to the next case. This is another patient who presented similarly, but just with sudden sensory neural hearing loss and vertigo attack. This is an axial T1 pre-contrast. As you can see, the fat is bright, fluid is dark. There's no enhancement of the turbinates. You can see the right internal auditory canal, cochlea, left internal auditory canal, cochlea. This is pre-contrast cochlea, and you can see a slight enhancement in the mid and apical turn of the cochlea on the left side. This is the same pre-contrast coronal view. Post-contrast, you can see this very slight enhancement. And this is a Fiesta sequence. And you look at the cochlea on the left and on the right. You can see the scale of vestibuli and tympani on Fiesta sequences. There's a black line that separates the two parts of the cochlea on these. So I'll give you a minute if you want to think about what this could be. And you're welcome to put it in as a chat or raise your hands or speak up if you would like to. So this is a case of acute labyrinthitis. So if you actually get an imaging study on a patient who presents very suddenly, and they have the classic picture of sudden hearing loss with vertigo, you can actually see that. Now, you have to remember vestibular neuritis and labyrinthitis. These are old clinical terminologies, mostly before radiology, MRIs were available. So if the patient just had vertigo, we would say they had vestibular neuritis. If they had sensory neural hearing loss, we would say, well, they must have labyrinthitis. For most parts now, we just call them vestibular neuritis and sudden sensory neural hearing loss with vertigo. But if you actually have the luxury of getting an MRI at the time, which I'm not saying you should order if they don't have hearing loss, but if they do and you get it and you see that enhancement, now you know for sure this patient has true labyrinthitis because the inflammation is within the labyrinths and doesn't involve the auditory and cochlear nerve. Subacute labyrinthitis would not enhance that avidly. Ossificans would look very differently. Same with interlabyrinthine schwannoma and intercochlear hemorrhage. I have cases that go over those, so we'll go over them later on. This is a very challenging case. It's a difficult case. A 30-year-old woman presenting with progressive bilateral sensory neural hearing loss and vertigo. What you're looking at is a post-contrast T1. You can see with fat suppression, the fat is suppressed, the fluid is dark. You can see the turbinates are enhancing. And the pathology that you're looking at, this very linear, thin enhancement that you can see and actually extends into the internal auditory canal on both sides. And you can see it much better on the coronal images that the entire meninges, leptomeninges are lighting up. It is not unusual to see enhancement in this area. You have to remember the inferior petrosal sinus feeding vessels are all live in this area. So you very commonly see enhancement in the pre-clival area of the meninges, and that's a normal finding. What is absolutely not normal is for you to see enhancement crawling into the internal auditory canal. When you see that, you start thinking of what's a differential diagnosis for this condition. So I'll give you a minute to think about what we're dealing with. Is this labyrinthitis, vestibular neuritis? Is this a lymphoma we're dealing with? Pachymeningitis or syphilis? So this is really the definition of pachymeningitis, which is thickness and enhancement of the meninges globally. This patient's pachymeningitis was actually from sarcoid. So this was a sarcoidosis. It was a very subtle enhancement, and we're able to establish the diagnosis by lumbar puncture. So it's not your very, very classic pachymeningitis. So let me show you. This is how bad pachymeningitis can get. You can see very severe enhancement of the leptomeninges everywhere around and including into the IAC. This patient has recurrent episodes of sudden sensory neural hearing loss, but he does not allow us to do any kind of a workup for him, lumbar puncture or even transmastoid biopsy. To give you an idea of how bad it is, looking at a Fiesta sequence, this is the thickness of his dura. You can see from there to there, and you can see most of the IACs filled up with the dura, and the nerves are pushed aside to the side, and that's why he develops episodes of sudden sensory neural hearing loss, which have responded all to prednisone so far, but we don't have a definitive diagnosis on him yet because of he doesn't allow us to do any workup for him. Okay. This is your more classic neurosarcoid image, so this diffuse enhancement, and of course these patients are a lot more symptomatic than having sensory neural hearing loss and vertigo episodes. Let's go to the next case. This is a patient presenting with vertigo and asymmetric sensory neural hearing loss. I'm going to play this one for you first. Was referred to me for a vestibular schwannoma or acoustic neuroma treatment, this patient. What you're looking at is axial T1 post-contrast without fat saturation. I'm going to play it for you again. And you can see there are areas of enhancement beside what caught the eye of the radiologist who diagnosed this as a vestibular schwannoma. You can see it extends up superiorly, and then you can start seeing other lesions everywhere else. And I'm going to show you the T2 because it's quite dramatic. You can see the massive edema surrounding this lesion, and you can see it also in the other parts of the brain as well, the massive edema surrounding these enhancing lesions. So this is a T2 axial. All right, and then let you think for a minute about what's the possible diagnosis behind this patient's progressive sensorineural hearing loss and vertigo attacks. We're dealing with acute labyrinthitis, vestibular neuritis, CNS lymphoma, acute meningitis, or is this neurosyphilis? So considering the multi-lesion areas with this severe enhancement around them, the only one that really truly fits is CNS lymphoma. That's what you're dealing with. Acute meningitis, as I showed you before, really involves the dura and the meninges. Labyrinthitis and vestibular neuritis, you have seen the similar cases before. Neurosyphilis really does not cause enhancing lesion throughout the CNS to this level. You can see enhancement within the cochlea, but nothing of this variance. So let's go to a companion case. This is a patient presenting with progressive ataxia, gait instability. Your usual, I'm just dizzy doc patient. I just feel dizzy, and upon further investigation, was what he was calling dizzy was really just ataxia and gait instability. This is his MRI scan. You can see on a pre-T1 T1 pre-contrast, T1 post-contrast. You can see on the flare and diffusion weighted images the massive edema around these two. So what are we looking at? Is this a stroke of the cerebellar stroke you're looking at? Is it metastatic disease you're looking at? Is it another case of lymphoma? Is it cerebellar GBM or neurosyphilis? I'll give you a minute to think about this. So this is a case of colon cancer metastasizing to the cerebellum. What you are seeing here are very solitary lesion with massive enhancement and central necrosis. This is very different than neurosyphilis and sarcoid and everything else that I've shown you so far. You can also see the amount of edema, just like the CSF lymphoma, that these lesions will generate around themselves within the brain. This is how a stroke would look like. You're looking at just edema in regions of the cerebellum. There's no enhancing lesion. This is on a head CT. This is on a T2 MRI, I'm sorry. And you can see on a diffusion weighted image, which is the best image for acute cerebrovascular accident, what the brain looks like after. This is a young lady that initially was diagnosed with BPPV after a chiropractic neck manipulation, and came to the ER with what was diagnosed as BPPV and discharged home, and came back a few hours later with much worse neurologic symptoms. And this is, you're looking at her CTA, and you can see the discrepancy between the two vertebral arteries and the amount of contrast inside of them. These are some questions I put in there for our participants at the Academy. Any questions before I proceed to imaging for pulsatile tinnitus? All right, so for imaging of pulsatile tinnitus, it is one of the more controversial parts of neurotology in terms of what imaging study to order. You can certainly order a temporal bone CT with contrast. You can order CT angio. You can order MRI of the brain with and without MRA and MRV. And neurotologists over the country have very different approach. Many always start with a CTA. Many do a triple study of MRI, MRA, MRV for every patient. One thing that you could consider is trying to order the study that you think will most likely capture the diagnosis first. It is very important to have a conversation with the patient and say the differential diagnosis is quite extensive, as you can see on your screen. And tell the patient that you would like to guide them through this process and avoid unnecessary study, which brings cost and radiation and other things for the patients to consider. And I can tell you every single patient so far I've had, they were very willing to do this slowly and one study at a time rather than get everything done at the same time to have the answer immediately. And more often than not, on your very first or second study, you can identify the cause and rule out everything else. So in general, what you want to do with pulsatile tinnitus is think about it as, is this a vascular sound that I'm hearing, or is it that the patient is hearing, or is it a non-vascular sound? There are quite a few conditions that are not related to vessels that can cause pulsatile tinnitus. Obviously, anything that creates conductive hearing loss, such as fluid in the ear, wax, anything like that can cause pulsatile tinnitus or pulse synchronous tinnitus. The other common things you hear are, of course, superior canal dehiscence, otosclerosis, many Meniere's patients, and interestingly, a large group of migraine patients also have pulsatile tinnitus. And most of the times, what differentiates the migraineurs from the rest of the folks is that their pulsatile tinnitus comes and goes. It's not constant. So if somebody has a pulsatile tinnitus that comes and goes, it is more likely than not you're dealing with something like Meniere's, or more commonly migraines, than things like AV fistulas and aneurysms. You can imagine those things, once they appear, they're not going to come and go. But in any case, it's important to work them up nevertheless. In terms of vascular pulsatile tinnitus, what you would like to do is differentiate if this is an arterial sound that the patient hearing, is an arterial phase sound that the patient is hearing, or a venous. The way you do that is you put your hand on the patient's internal jugular vein and gently press until you feel the carotid pulse. If the sound disappears, you're dealing with a venous phase pulsatile tinnitus. By far, the most common diagnosis in that category is intracranial hypertension. There are other patients with sigmoid sinus issues that can mimic this condition, but that's a lot more scarce. And I can tell you, sigmoid sinus dehiscence, which has recently gained a lot of popularity as the cause of venous phase pulsatile tinnitus, may be a red herring in many patients. Many of these patients have intracranial hypertension and can't diagnose it until you've looked for it, and particularly done a lumbar puncture. We do see sigmoid sinus dehiscences in many patients who have no pulsatile tinnitus, but just don't have any bone over their sigmoid sinus. But that said, you do see venous phase pulsatile tinnitus with patients with venous diverticulum and so on and so forth. On the arterial side, the more common things are issues with internal carotid arteries, such as intercarotid stenosis, and with the ultrasound, Doppler ultrasound, you can diagnose that. If the sound is audible to the patient's spouse, or you can hear the sound with or without a stethoscope, pretty much the only thing that would do that is an arteriovenous fistula. None of the other conditions can generate a sound that is so loud that you can actually hear it, or patient's spouse can hear it in bed. So if you hear that a patient has an audible, or you can hear it with a stethoscope, that's where you want to go down the pathway of working up an arteriovenous fistula. The malformations don't cause sound that's usually that loud. Aneurysms, and of course glomus tumors, any vascular tumor in the middle ear that can create pulsation that the patient can hear. So let's go through some cases together. This is a patient that was referred to me for a pulsatile tinnitus. What you're looking at is a temporal bone CT with contrast. I'm sorry, this is a CT angio, it's not a temporal bone CT, because the slices are very, very thick. The CT angio slices are usually around 1 millimeter or more, whereas the temporal bone CTs are supposed to be 0.6 or smaller. I'm going to play this for you one more time, so pay attention to the sigmoid sinuses. This patient has a right-sided Pulsatile tinnitus, that's her right sigmoid sinus. That's the left one coming down. She's obviously a right dominant. Continuing superiorly. And this is a very important image to pay attention to. Go back on the sigmoid sinus. You don't see any diverticulum, obviously, here. So what does this patient have? Intracranial hypertension, sigmoid sinus diverticulum, dehiscent jugular bulb, AVM, or Paget's disease? I'll give you a minute to think about that. So this patient actually has intracranial hypertension, and it is so bad that you can actually diagnose it on a CT scan. It's unusual to be able to see an empty dilated cella so beautifully on a CT scan, but I'm gonna take you back up to that image right here. See that? If you look very carefully on a CT scan, and unfortunately we can't do it here, and adjust the contrast, a lot of times you can actually see a very tortuous optic nerve that goes along with an empty cella in many patients with prolonged history of intracranial hypertension. The thin bone over the sigmoid here was a red herring. This patient had no issues from the sigmoid causing it, and many people have dehiscent jugular bulbs, and it really doesn't cause any sound that that patient will perceive. So this is her MRI scan. You can see a completely dilated empty cella. So the pituitary gland is compressed down here, and you can see the pituitary stalk there. This is a T1 sagittal that you're looking at. Of course, the fluid here of the CSF is hypointense compared to the brainstem. This is a T2. I've zoomed in for you on the eye so you can see the tortuosity I was telling you about. You can also see that within the optic sheath, the majority of the optic sheath is actually fluid. The nerve is sort of compressed in the middle. If you look very carefully, you can actually see her papilledema. You can see the optic disc bulging out on this image. And this is another sign that radiologists look for. It's a flattening of the posterior globe. The posterior globe is supposed to have the same contour as here. If it's bulging inwards or it's very flattened, that's another sign for intracranial hypertension. Unfortunately, many of these signs are found in older patients and they're red herrings, but putting them together with a clinical picture, I may warrant doing a lumbar puncture. Let's go to our next case of a pulsatile tinnitus. This is a patient presenting with pulse synchronous or pulsatile tinnitus on the right side, and the sound does not extinguish with IJ compression. Interestingly, many of the patients with venous phase pulsatile tinnitus, they will also tell you that when they turn their neck, the sound stops because you compress the IJ when you turn your neck all the way to the contralateral side. Or they say, if I put a pillow underneath my neck, the sound will stop. So they decipher themselves that the sound is coming from that vessel. I'm going to let you study this image for a minute before I go through them with you. So going through the panels, what you're looking at, this is a T1 axial pre-contrast image. You can see the fat stranding in these areas, normal fat signal, which is bright. You can see the fluid signal that is hypointense or darker compared to the brain. You can see a lesion here, posterior to the carotid artery. This is a T1 scan now with post-contrast. Has some level of fat suppression. You can see an enhancing lesion really based on jugular bulb posterior to the carotid artery. This is it on T2. It's fairly iso-intense to the brain. And this is again T1 coronal. The arrow here is pointing to these dark spots in the middle of the tumor. Let's see what your diagnosis is. So this patient clearly has a glomus jugulare tumor, which is really centered around the jugular bulb. You can see these flow voids, these dark spots on post-contrast T1 are giant vessels, and the speed of blood is so high within them that you don't capture the same protons as or the contrast material as is going through between the excitation and the recording phase of the MRI or relaxation phase of the MRI. So this sort of a speckled pattern that you see, these are all giant blood vessels as characteristic of glomus tumors. To show you a companion case is different. This is a glomus tympanicum. I'm going to play this for you. Her mastoid is seen here. It's a pneumatized mastoid. It's full of air cells, but there's no air inside of it. So this is a mastoid that's considered pneumatized but not aerated. And you can immediately see when you get to the middle ear level that the middle ear is filled with soft tissue signal. You can see the stapes bone here, malleus and incus. You can see the basal turn of the cochlea, the vestibule. And as you come more inferiorly, you can see there's a mass filling up the entire middle ear. And the reason you have the fluid here in the mastoid is because it's completely obstructing the opening of the eustachian tube. It's actually slightly eroded the bone over the carotid there. What you want to pay attention is this area. You can see this is the hypotympanum. You're 1-2 slices below the round window niche. So this is the round window niche right here. This is not the round window. The round window would be in that area. And you're going inferiorly, and you can see the posterior semicircular canal there. You want to follow this tumor and see if it continues into the jugular bulb. And it's very hard at times to decipher if you're looking at a glomus tympanicum that is extending inferiorly or a glomus jugulare that's extending superiorly. And for this reason, for the larger ones, some people just call them, jugular tympanicum, that they don't bother where they come from. In reality, it does make a difference because in terms of the blood supply and pattern and embolization, it does make a difference if this tumor arises from the middle ear or from the dome of the jugular bulb and extends upwards. If you want, the best way to diagnose if you're looking at a jugulare or a tympanicum is look at the bone that's superior to your jugular bulb. And if that bone, there's a plate of bone that separates the middle ear from the jugular bulb in most patients. If that is eroded and the tumor is extending upwards, you're looking at the jugulare. You see the bone here is still solid as you go slice by slice. So what we're looking at is a giant glomus tympanicum. Now, word of caution is that in many patients, what you're looking in this area and think you're looking at bone marrow, similar to the clivus, is actually tumor cells. So glomus tumors in general have this pattern of extension that goes through the bone and simulates bone marrow. And for this, you need an MRI to look at this area and see if there's enhancement in this area or not to know you're dealing with tumor here, or is it just bone marrow. So be very careful when you're planning your surgeries or radiation for glomus tumors. What a lot of time people think is just no tumor extension and just looking at a normal bone is actually tumor extended into the bone simulating a bone marrow. So no other questions. We'll go to the next case. This is sort of a companion image of what an arteriovenous fistula would look like. You can see on MRI sequences, the difference, sort of this bag of worms you're looking at, and same on CT with contrast is a massive influx of the arterial pressure into the venous size causes engorgement of all these venous structures. And this is an angiogram of the same area connecting the two. In terms of the pulsatile tinnitus imaging for a non-vascular, you obviously would obtain a temporal bone CT without contrast for those patients. And there's a differential diagnosis. Obviously, if you see a patient has a middle ear effusion, you don't need to obtain a temporal bone CT unless you're worried about CSF leak or something else. Otosclerosis, superior canal dehiscence, and Paget's disease are other conditions that cause conductive loss or pseudoconductive loss. And because of that, the patient will have pulse synchronous tinnitus. This is an axial view and coronal and partial view of a superior canal patient. And you can see it's important to look at all three because it's really nice to see that thin bone or lack of bone on a coronal, which you may not see always with stental and partial view as well. You can see these on the coronal view as well. This is a case of otosclerosis. You're looking at a temporal bone CT, left ear, obviously. You can see this halo around the temporal bone, around the cochlea, and extends actually into the labyrinthine bone surrounding the vestibule and the balance canals as well. They talk about a halo around the cochlea. Unfortunately, I can't do that on this image because these are exported images, but one really nice way for you to see these, especially when they're very subtle, is to invert the image black and white and look at the negative image. And these would be seen so much more beautifully on an inverted image than a regular white image. You can see the halo continues all around the cochlea here. Okay. So what would be your imaging modality of choice for patients with pulsatile tinnitus? Again, I would say after you've done a thorough history, physical examination, looking at an audiogram, let that guide you. If you have a patient with a completely normal examination and conductive hearing loss, Carhart's notch, absent acoustic reflexes, obviously a temporal bone CT is more than sufficient for you to diagnose possible otosclerosis. The patient walks in, they have Tullio Hennebert, they can hear the eyes move, they can hear a tuning fork on their medial malleolus or on the knee. You're really dealing with superior canal dehiscence and nothing else, and a temporal bone CT without contrast would diagnose it. If it's a venous phase sound, it's a patient who is woman, childbearing age with central obesity, you're more likely than not looking at intracranial hypertension. Now, for intracranial hypertension, you can certainly order an MRI without contrast and an MRV to look at the venous structures, because once in a great while, you may have a patient that has a stenosis of transverse or sigmoid sinus that creates the intracranial hypertension. So you're not dealing with pseudotumor or idiopathic, you actually have a cause. So if you have a suspicion the patient doesn't match your classic demographics of pseudotumor or intracranial hypertension, it is important to not only order the MRI of the brain and IAC with and without, but certainly get an MRV as well to look for other anomalies in there. For patients that you're really concerned about AVFs, AVMs, glomus tumors, you can certainly order the CT angio or MRI as well. So I'll leave this up for a second for you to study, and these are recorded so you can return back to this to look at the importance of which study to order and when it's best indicated and when it's a poor choice for that study. As is listed here, the contraindications are listed here as well, and which diagnosis is a poor choice to order. So if you're really concerned about intracranial hypertension, ordering a CT angio is really not a very good idea because you're exposing that patient to massive amount of radiation, and you can barely see an empty cell potentially on a CT angio. All right, so next we're going to go over imaging of the cerebellopontine angle. Let me just check, see if there are any questions. Good, all right. Again, these are important images for you guys to review for your board examination, because CPA tumors tend to show up on board exams. So you want to master and make sure you can easily differentiate vestibular schwannoma from a meningioma and so on and so forth. This is our first patient. I'm going to let you go through the images for a minute before I go through them with you. What you're looking at is a head CT, and even on a head CT, you can see there is an anomaly in the cerebellopontine angle on the right side. Then you're looking at a T2. You can see the CSF is very bright, so you know you're looking at a T2, and the lesion is hyperintense on T2. On pre and post contrast, I'm only showing you the post contrast, but even on the pre-contrast T1, the lesion is hypointense to the brain and isointense to the CSF. So it's the same color as a CSF on a T1 and on T2. Now, this is the key image which you're looking at here. This is a diffusion weighted image. In particular, this is a non-echoplanar diffusion weighted image that you're looking at, a DWI. And then lesion is extremely bright on DWI. So the most likely diagnosis for this patient is which one of the following? Acoustic, meningioma, epidermoid, arachnoid cyst, choroid plexus papilloma, or ependymoma. So this is clearly a case of an epidermoid tumor, and the key is the diffusion weighted images. No other tumor would be so bright on diffusion weighted images, which are also very important sequence to obtain for cholesteatomas, because as you can imagine, epidermoids and cholesteatomas are virtually identical in terms of cell that rises to them. So this is an important image to recognize. This is a diffusion weighted and how bright the tumor is. What this differentiates from is its cousin, which is not a tumor at all, and it's called an arachnoid cyst. Arachnoid cysts are just loculations of the CSF. And before diffusion weighted images went around, there were patients that would actually have a craniotomy done for these because the surgeons couldn't tell for certain if they're dealing with an arachnoid cyst or they are dealing with an epidermoid tumor. So if the patient were very symptomatic, they would take a patient to the operating room. And you still see those patients once in a while in your practice these days for follow-up and had a craniotomy for an arachnoid cyst. This is what the cyst looks like. You see, it has the identical signal as the CSF on T2 and T1, but on a diffusion weighted image, there is no signal of it, and it's identical to the CSF. If you are having a difficult time looking at a diffusion weighted image, am I looking at a non-echoplanar? Is it ADC I'm looking at? Is it DWI? Is this a right DWI? If you're having a difficult time, look for the CSF signal. And if whatever you're looking at perfectly matches the CSF signal, this is simplifying this a little bit too much, but for most intents and purposes, if the lesion you're looking at follows the same signal pattern as a CSF through the diffusion weighted sequences, you're looking at an arachnoid cyst, not an epidermoid tumor. Let's talk about this. This is a patient that was referred to me for right hearing loss, and MRI was done, lesion was identified. I'll let you go over this for a minute, and then I'll go over it with you. So what you're looking at on this left far panel is a fiesta or KISS sequence of the brain at IAC levels. You can see the normal left IAC with fluid in the IAC and these little nerves traversing it. You can see the mid-turn and apical turn of the cochlea. You can see the vestibule there, even a portion of the lateral semicircular canal. It's part of the posterior semicircular canal on that side. You can see that the right IAC has a lesion that's excluding the CSF. Not only from the IAC, if you look very closely, it's actually, there is no bright usual signal within the labyrinth as well. So whatever this thing is, has a component in the IAC and has a component in the vestibule. This is a T1 pre. Again, you can see the fluid is dark, CSF, the vitreous is dark, fat is bright. You're looking at a T1 pre-contrast. The turbinates and nasal mucosa don't enhance. This is the right IAC, and you can see whatever this lesion or lesions are, they enhance avidly in the vestibule and in the IAC. So what are we dealing with? Is this an acoustic? Is the IAC meningioma? Are we dealing with another epidermoid, arachnoid cyst, choroid plexus, papilloma, or is this a facial nerve schwannoma? I'll let you think about it for a minute. So this is an extremely challenging case. What you're looking at is actually an acoustic neuroma. Reality, what this thing is an intralabyrinthine schwannoma that started within the vestibule and extended itself into the internal auditory canal over a span of a decade. And then the connection between the two tumors slowly dissipated, so you can't see it as well. But that's the only thing that can explain this tumor that has sort of the two lobes within the inner ear and the IAC. Now, why is this not a facial nerve schwannoma? Because you can see the facial nerve really beautifully there in the tympanic segment and the geniculate, and there's no enhancement. This is not a tumor. You can also see the masses within the vestibule there. The facial nerve schwannoma wouldn't necessarily do that. So companion cases, this is what a facial nerve schwannoma classically looks like. Sort of a dumbbell-shaped tumor with it extending from the IAC segment or cisternal segment into the geniculate and tympanic segment. Classic board question that you would see here is a very widened labyrinthine segment that instead of its usual 0.86 millimeter diameter has dilated to about maybe a couple of millimeters there. Very smooth edges. This is not destroying the bone, it's remodeling it. You can see it iso-intense to the brain on pre-contrast T1. On a fiesta, you can see it here, and on a post-contrast. And really, there's nothing else that would give you this image but a facial nerve schwannoma with this kind of enhancement. IAC meningiomas are very hard to diagnose at times because they can very easily simulate vestibular schwannoma or acoustic. They have identical, almost identical signal pattern on pre-contrast and post-contrast. What you can diagnose them with is that at times they actually do have enhancement of the meninges right next to them, what they call a dural tail, but that's not always a classic sign. You can actually see that with vestibular schwannomas as well. So if tumor is this little, they become very difficult to diagnose if this is truly a vestibular schwannoma or an acoustic. This is a much smaller one noted there. Let's go to a companion case. This is patient presenting with left-sided sensorineural hearing loss and vertigo attacks. These are the images. I'll let you go through them for a minute, and then I'll go over them with you. So going through the images, what you're looking at here, so you can get a CSF, it's very bright. So you're looking at a T2 axial. You can see a lesion that is sort of very sessile, attached to the temporal bone in this area and extends into the internal auditory canal. It is iso-intense to the brain on a pre-contrast T1. On a post-contrast T1, it avidly enhances, and it has these sort of dural tails. And this is on a diffusion weighted image. It is actually fairly bright on a diffusion weighted image. This is not an easy case, guys. So I'll let you think about it for a minute. These are the possible tumors: acoustic, meningioma, epidermoid tumor, arachnoid cyst, facial nerve schwannoma, or is this a lymphoma case? So this is a very difficult one, and to correct this, the only person who diagnosed this was our neuroradiologist. The rest of us thought this was a meningioma because it has this very classic, you know, slightly hypointense to the brain in certain areas, and it's iso and hyper. It has this sort of on plaque sort of sessile classic meningioma. It had all these dural tails. And you can see it's iso-intense on T1. So every one of us thought that this is going to be meningioma, but our neuroradiologist looked at a diffusion weightage image and see how bright this is. from the rest of these, you know you're not looking at an epidermoid, correct? Epidermoid would have been the same color as the CSF here. This is much darker than a CSF color. So the only thing that follows this pattern is actually this. This is a lymphoma. This is a very bizarre case of lymphoma of the cerebellopontine angle, and we actually did a small biopsy of it and confirmed that that is what it is. This patient also technically could have had just an LP done and spun the cells down from the CSF and see if it is. But this is a very strange case of a lymphoma in the area. Meningioma would have looked identical minus the bright signal of the diffusion. The reason for the bright signal is the amount of protein that the lymphoma cells have, whereas meningiomas don't have that much amount of proteinaceous material in them. Let's go another case. This is a favorite for type of case for neuro-otology boards. I don't think you're going to be seeing this on a regular board, but this is one of those cases that really nothing else looks like it. You're looking at a temple bone CT here. You can see there's a destructive lesion in the posterior aspect of the temple bone. There's the posterior semicircular canal there. The lesion is destroying the bone in this area. This is a lesion on T1, and it's hyperintense to the brain. This is on T2, and it's still hyperintense to the brain. And I haven't shown it to you here, but you can't say if the lesion enhances or not because it's already bright on T1. So the only thing that causes this much destruction in the posterior aspect of the temporal bone right next to the posterior semicircular canal, it's hyper on T1 and hyper on 2 is one thing. And you need to know what that is. So let me have you think about it for a second before I give you the answer. So this is clearly a case of an endolymphatic sac tumor. Endolymphatic sac tumors are extremely proteinaceous. They're like papillary type of adenocarcinomas. So just like a papillary thyroids or melanomas, because of the amount of protein that they generate, they tend to be fairly bright on T1 and T2. And the giveaway is where they grow, is right where the endolymphatic sac used to be next to the posterior semicircular canal, and they cause massive amount of bony destruction. This is actually a fairly little one. This is one of the ones I took care of a couple of years ago. They can destroy the entire bone, erode the cochlea, facial nerve, middle ear. They don't respect anything. They're fairly aggressive tumors, and they can be extremely vascular, as you can see in this tumor. They can cause massive bleeding around themselves, and so on and so forth. Now, to end here, our advanced cases, these are tumors that you may never see in your career. These are fairly rare tumors in the cerebellopontine angle. I just put them here just for completion's sake. This is a case of an ependymoma. These are tumors that actually grow from through the fourth ventricle into the cerebellopontine angle. And you can see on this T2 image, the tumor is actually coming from here, but instead of growing into the CSF space of the spinal column inferiorly, it's growing into the cerebellopontine angle, and was confused with acoustic neuroma and a meningioma. But you can see from its enhancement pattern, it really doesn't enhance at all. It has a very diffuse, it has a very diffuse patterns of enhancement. And it's fairly isointense to the brain, nothing on diffusion. And this is the only thing that looks like that is an ependymoma. And this is another one that was confused as a, misdiagnosed as a vestibular schwannoma. And this is a choroid plexus papilloma. They come from that tuft of choroid plexus that grows from the fourth ventricle. Again, you can track this inside of the fourth ventricle. You can see that's where the fourth ventricle is. And these tumors tend to be extremely vascular. And you can see we had to embolize this one pre-op. Aneurysms can mimic tumors of the cerebellopontine angle, but again, extremely rare. But this is an old image from my mentor, Dr. Jackler. I have yet to see an aneurysm that looks this beautifully, just like an acoustic. But what you're looking at is the layers of blood clots within the aneurysm, creating this sort of onion pattern. And as you can see on a T2, the hemosiderin deposits are extremely dark on T2 images, and you know what you're dealing with is an aneurysm. This is our last case. This is a fairly difficult case. It was diagnosed as an acoustic neuroma for a patient with vertigo attacks. What you're looking at, this is a T1 pre-contrast. You can see the lesion is hyper-intense to the brain. You can't say this is enhancing, correct? Because this is, there's no contrast given to this patient yet. So this is an hyper-intense on T1, is iso-intensive to brain on Fiesta/KISS and T2, and really doesn't enhance much if you think about any enhancement. And then if you do a fat suppression, it disappears. And there's only one thing that would do that. It's the tumor that's following the signal pattern of fat. So what you're looking at there is actually an IAC lipoma. They're extremely rare tumors, and they're fairly innocuous, and you can just monitor most of them. They don't cause any harm. With that, I'll finish here. You can hear my children running around, creating havoc in the middle of a pandemic. So I'll stop here. If there are any questions, I'll be delighted to answer. If not, I will thank you for your time. No, it is my pleasure, and let me know if I could be of any service. My email is Monfared, my first initial, my last name, at mfa.gw.edu. It is on the class list, the Excel sheet, so you can find it there and reach out to me if you need it. Take good care, guys.
Thank you. We appreciate your time.
Thank you so much for organizing this. I'll see you on Friday.
See you then.
Thanks.